there was nothing going on in the sinuses. And I'm like, well, how is the virus getting in there causing that? Like, how is it causing smell lice when there's not, the virus can only enter your body if it has a receptor, like an ACE2 receptor to allow it to get in there. But there's not a lot of ACE2 receptors in the olfactory bulb and tract, so how is it affecting the smell? And then we had some fascinating cases when the vaccines came out where people got vaccinated with a specific type of vaccine and would have a very distinct type of smell loss or abnormal smell that smelled like burnt rubber. And we published it.
Welcome to Frame by Frame, Rethink Imaging, a podcast by Immunologics. Here, we explore the intricate world of medical imaging, aiming to dissect the field and inspire both professionals and curious minds alike. I'm your host, Chris St. John. Welcome back to Rethink Imaging. Today's guest is Dr. Claudia Kirsch. She is a professor of neuroradiology at Yale School of Medicine, and she's currently finishing a PhD focused on how viruses affect the nerves and structures at the base of the brain. After experiencing a severe case of COVID herself, she began asking new questions about how infections like COVID, HPV, and Epstein-Barr virus interact with the head and the neck. Her work uses advanced imaging to look at the pathways most of us never hear about. Welcome to the show, Dr. Kirsch. Claudia, what would you like me to call you today?
You can call me Claudia. I have 3 older brothers, so I've heard every name in the book. So Claudia works fine.
Well, beautiful. Claudia, I am so thrilled to have you here today. And so let's just dive in, right? So when we spoke before this recording today, you told me COVID changed your life and pushed you back into deep research. Can you just tell our listeners what happened and what it unlocked for you?
Yeah. So I was invited to speak in Australia at the Australian and New Zealand Skull-Based Society meeting. So I was very excited. I went out there and my husband and daughter were supposed to come join me. This was back in March. And when the COVID epidemic was starting. And I was there actually lecturing on EBV and HPV. And I started, I was reading about it in the newspaper. And I was out in Australia having an amazing time. Told my husband and daughter, you need to come join us. And my husband was like, you don't understand what's happening here in New York. We're not going to come join you. They're shutting things down. Like he was like in panic mode. And he said, we'll get trapped there. This is, and I was, having a great time in Brisbane, Australia. And then I started reading about this stuff and they started shutting things down and they put the clamp down on flying back into England. They were shutting that down and the meeting ended and the organizer said, we need to get you back to the States because everything's closing down. And so I went to the airport and they were hauling people off that were supposed to go to the UK on the flight. They had air marshals there. It was a whole new world was starting. And I remember getting on that flight. It flew from Brisbane directly to LA. When I got to LA at the Delta Lounge, they're like, you can't touch anything. People had gloves. I'm like, okay, this is interesting. And then I flew into New York City and I arrived in JFK. I was the only one going through customs. It was eerie. It was very, very strange. I'm like, this is bizarre world. I remember saying, this is the strangest thing I've ever seen. And then I was home for a couple of weeks. And then I started feeling, I was working, doing whatever. And then I started feeling tightness in my chest. And my eyes started getting, and I couldn't breathe. And I went to the doctor and I remember she said, you've got COVID. And I was like, what do you mean I have COVID? She says, it doesn't discriminate. Like, you've got COVID. You need to go home, quarantine. And it was the beginning of March. So I went home, told my family and it went from initially feeling a little bit to the point it was like someone was taking a hatchet to my back. I couldn't breathe or move. I was spiking temperatures, 110. I was quarantining. My family was rolling the food into me and I got very sick and couldn't breathe or function. And I remember reading about 2 patients in China. One was a doctor who got COVID, went into the hospital, got intubated, and then died. One was a nurse who quarantined herself in a hospital room, got pretty sick for about 10 days, proned, and survived. And I said, I'm proning. I'm not going on a ventilator. I'm not doing that. They had a ventilator teed up for me. My O2 sats, I had an O2 sat monitor, my sats dropped. I just proned. It was miserable for about 10 days of hell. It was that initial infection. It was brutal. I mean, if you saw pictures of me, I just looked like death warmed over. I could barely breathe or move. And then I recovered. And after about 10 days, my fever came down. I was functioning. I was okay. They set me up with a home workstation for what I do in neuroradiology. I started feeling better. And I contacted my job and said, I'm feeling fine. You can put me on call. And that was the first weekend in April. And I started taking cases. And every case I had was somebody who had either a brain bleed from a venous infarct from COVID, somebody with massive infarctions, massive inflammation. People were dying. And it was horrifying. I had a little bit of survivor's guilt. Like, I'm fine. I'm working. I'm reading cases. Like, what the F is going on here? Like, it was a wake-up call, a shocker. And so, it was the very beginning of everyone trying to figure out what was happening. And it was pretty bad here in New York. My hospital in particular was overrun. They had to peel out beds and put, ICUs in there. And we had people who were radiologists trying to run the ventilators. It was crazy. And I was like, I want to understand this disease. Like, I want to go back and truly understand what's happening and why are things happening to patients. These don't make sense to me. And so I decided to go back and do a PhD. I got recruited to Yale and my thesis is in and I have my defense coming up and there you have it. So I feel like one of the lucky ones, but I also realize there's a lot we still don't know, which is happening in COVID. And we're still trying to piece together what will happen to those who've had COVID, who are at risk for long COVID and long COVID brain sequela, which is, I think, going to be impacting all of us in the next 10 to 20 years.
I'm not familiar with that term, the brain sequela. Would you mind explaining that a little bit to me?
Neuropask, or, the not neurologic sequela post-COVID, because what happens with some patients, they have memory loss or brain fog. They just don't feel like they're functioning. They can't function back at the level they used to function at. So one of the papers, I was not the primary author on that, but it was worked on that paper with my colleagues, Dr. Preeti Balanchani's lab at 7T at Mount Sinai, where I'm adjunct associate as well, was working on one where we were using AI and 7T and looking at what are called the little space in the brain called the perivascular spaces. And we saw that these were significantly enlarged in patients who had a larger body mass index and had long COVID neurologic symptoms, meaning brain fog. They couldn't remember things. Their memories weren't good. They couldn't function as well. And we are still seeing that in some patients. They have difficulty with long they're just not back to themselves. And we saw the changes in the brain and we published on that. And then
I feel like that's me, by the way, too. I neatly fall into that, but I believe I fall into that bucket. I was vaccinated and throwing weddings all the time by the time I got COVID in late 2022, I think. And my only symptom was a runny nose for about 24 hours, right? I was vaxxed, I was boosted. But since then, my vocabulary recall is astonishingly below what it used to be. Like there are even times where I'll like have trouble coming up with the word like bicycle. I'm like, oh, it's that thing. It's got wheels and gears and you ride it to work. Like
there are many people are embarrassed to talk about it. Many people are like, they know something's not quite right, but they don't know what's going on. And even more fascinating to me was we had a series of patients, a couple of things that really have stuck with me. We had patients coming with, smell loss, right? But there was nothing going on in the sinuses. And I'm like, well, how is the virus getting in there causing that? Like, how is it causing smell loss when there's not, the virus can only enter your body if it has a receptor, like an ACE2 receptor to allow it to get in there. But there's not a lot of ACE2 receptors in the olfactory bulletin tract. So how is it affecting smell? Like that is like, how is that happening? How is it getting in? We are still trying to understand how does it get into the brain and then cause these changes? It's going through the bloodstream. Is it getting through there? How is it doing these changes we see? How is it causing that loss of smell? And then we had some fascinating cases when the vaccines came out where people got vaccinated with a specific type of vaccine and would have a very distinct type of smell loss or abnormal smell that smelled like burnt rubber. And we published it. The other patient wrote to me and sent me their scans, and they have the same exact areas. So we think it's probably an inflammatory response that caused that. Specifically, though, to small little neurofibers that we were the first to they've been known about since the 1900s in pathology. They were not the first ones to write about them. They've been published in beautiful pathology diagrams since 1914, 1917. But nobody had ever published them in imaging. And I was like, why? We can see these. Let's go back and look. Can we identify them? And we also just recently published on the changes in that as well. So lots still that we're learning, but excited to find the stuff that we are seeing.
Yeah, for sure. I want to come back to the nerve thing, but before we get there a little bit, your PhD work is about viral mediated disease in the skull base. Would you mind just, breaking that down a little bit before we start digging into other stuff?
English, So
yeah, let's lay that foundation.
Yeah. So let's start to think about the fact when we think about the world around us, there are more viruses than there are stars in the sky. Like, just let that fact sink into your brain for a second. There are more viruses. It's the most abundant microbe on the planet. There are more viruses than anything. It's like trillions. They're all around us all the time. They are everywhere, whether we like it or not. And in fact, our own DNA is about 1/12 retroviruses that have incorporated into your DNA over time. So whether we like it or not, they're part of who we are as well. So I think we need to understand that in order to better help treat and understand diseases. So, for example, HPV, human papillomavirus, right? It's a very stable virus. It has like these little shells. That virus has been around for a very long time. That virus is the number one cause of oropharyngeal cancer in the head and neck. It's the number one sexually transmitted disease. I'm going to just put that right out there. Worldwide, the number one sexually transmitted disease. We know it causes cancer in the orogenital region, but it is now the number one cause for cancer in the head, neck, and the tonsillar region. It likes to go deep into the reticular tissues of the tonsil. Why it only causes cancer in one tonsil, we don't know, but we know it's a leading cause of cancer. And so we also had seen this in kids where it was sometimes in the oral cavity, and it may be because when they lose their tooth, maybe they were exposed in the birth canal, that virus gets into the deep reticular tissue when that tooth is lost, and then it likes to replicate in the deep basal layers. So that is a virus which is a leading cause for head and neck cancer that we are still determining different subtypes of, and we know that it can behave, and often has a better prognosis than smoking and drinking cancers, which are more superficial layers. But we are still trying to understand why is it some people are getting these cancers, others aren't, how the immune system regulates that. Why do people have a better prognosis often? It's more radiosensitive. It often presents radiographically slightly differently. Just finished editing and reviewing a paper. They're looking at that. And there's a lot more, I think, with AI that we can analyze how this tumor behaves to kind of determine. So that is a virus which causes cancer. And now let's talk about EBV. Epstein-Barr virus is ubiquitous. We all have it, whether we like it or not. We've probably been exposed. We have a little episome of EBV hanging out in our cells right now. It's there, whether we like it or not. It is incredibly infectious. And we know from the Harvard study where they looked at military recruits that if you were obese in childhood or if you had lack of sun exposure and you had the Epstein-Barr, you're more likely to develop multiple sclerosis or a brain demyelinating disease. So why is that? What is going on? And it's probably because that virus is very clever, right? The virus hangs out in your immune system, and then it stays there until your T cells and B cells, and they can't regulate enough. And then when it activates, it can do a couple of things. It can activate the B-Mike oncogene, and you get like these Burkitt's lymphomas. But in other patients, they're getting demyelination disease. And it may be that when it's replicating, it's exposing to the immune system, your own fat or proteins that are associated with myelin, leading to the body to attack itself. So to me, it's really important to understand the mechanism of how these things are doing that, so we can then figure out how to treat patients, how we can better evaluate them, how we can improve them. So use the tools that we have, especially higher resolution imaging, artificial intelligence, to understand how that disease is caused, and then we can improve treatments and outcomes for patients, which to me is the bottom line, right? So everyone can thrive and do better.
So is it safe to say like we just don't have an entirely clear picture of how viruses impact the head and the neck and the ways in which they cause harm, right? We don't know if it's direct infection or immune reaction or like what it is exactly that is triggering these cancers.
For example, how is SARS-CoV-2 getting into and causing smell loss? How are these cells being affected? If you don't have ACE2 receptors, how is it then damaging the olfactory bulbs and tracts? Like, it has to have an ACE2 receptor. We know that for any virus, like when you go to a hotel, you can't just enter any room. You have a key that allows you to enter your room because it fits that lock. Same thing with a virus. It has to have a receptor for it to bind to that allows it to enter, then get to the cells and affect them. So we know for the SARS-CoV-2, the spike protein specifically binds to the ACE2 receptor. So I have to look for areas that have ACE2 receptors. If there are no ACE2 receptors, then it's not getting into that tissue. But if it's damaging that tissue, then it's affecting something that is, involved with that tissue. So I was very keen to look for where there could be ACE2 receptors, like how is it getting in from the olfactory tracts and bulbs? And that's why when we saw these little nerve fibers, these Nervus terminalis, it was key for me when we look at animal models, they're loaded with ACE2 receptors. So I'm like, okay, now we know there's this, but they're tiny. They're small little nerve fibers. They're very delicate. They're unmyelinated. So if you break them, like when you do an autopsy, you could easily damage that tissue if you take the brain out. And they're often not taught to students in medical school. So a lot of people are unaware of them. They were officially
I had never heard of the nervus terminalis.
not alone. Not a lot
Right.
of people. Not a lot of people even in medicine are even taught about them. Their importance.
And so where exactly is it, and like where is that pathway?
Fantastic question, and exactly right. So, and I think your brain's working great if you know to ask these questions.
Thank you.
So they are very tiny little unmyelinated fibers that run next to your olfactory bulbs and tracts. And these little unmyelinated fibers actually go all the way back into the hypothalamic region, which is literally the lecture I just gave to our incoming fellows and lecture on, because the hypothalamus, we are doing some work trying to sub-segment out this very critical area. These unmyelinated fibers are preserved in all vertebrate species, these little nerve fibers. They run next to my olfactory bulbs and nerves along the olfactory tracts. They're really important because all species, all vertebrates, even whales and dolphins that don't have an olfactory system have these little key fibers. These little fibers are associated with nitrous oxide and with the immune response. So they control, and nitrous oxide controls vessel dilatation, so blood supply. So we know they're right next to my olfactory bulbs and tracts, which are really, we call them, we say there's 12 cranial nerves, but really the first two, the optic and the olfactory, are tracts. They're different myelin from the brain, from oligodendrocyte. So the olfactory bulbs have next to them these really important little fibers controlling the blood supply, which goes to those tissues. So it may be that when you have a virus that affects them, they get activated, they're releasing the nitrous oxide, controlling the blood supply or damaging the blood supply, getting to the olfactory bulbs and tracts, that we saw the response. And over time, usually about 3 months, that tissue can regenerate. So most people do regain their sense of smell back in about 3 months. Some people don't. 15, 20 have difficulty with that. There are smell training and tests. People are working on that. But we're still trying to uncover what happens. And we, in addition to noting that patients had this olfactory tract volume loss and abnormal high T2 signal that were affected, that was published by others, but we also noticed that as well in high resolution. We are now looking at trying to trace these tria from the olfactory bulbs and tracts to the temporal lobe region, which is where your memory, your hippocampus is. That's where you store memory and how you function, to see how it's relating into those tissues. And we were seeing that there's alterations in those patients that may be associated with depression and behavior. And we know that when people lose their sense of smell, it can be associated with depression. And importantly, loss of smell, which is a really critical sense if you think about it, is one of the first things that goes in Alzheimer's disease and in Parkinson's. And many people are unaware of that. And it can be associated with depression. So it's a really important thing. And more importantly, when you think about how smell works, we don't know how it works. So it's a phenomenal area for research. I have my own theories. I think it's probably frequency mediated, but there's arguments about that. And that's a whole nother discussion topic for another day. But smell is one of the most important things. We wake up in the morning, we shower to smell nice, we want to smell good. You recognize your partner innately by a sense of smell, and babies can smell with their mother. I mean, your tea or your coffee that you drink, and it has a smell that you like, makes you feel good, taste your food, all related to that. And
so related to memory.
Absolutely. Smell and memory, like from Proust, Madeline.
Right, yeah, exactly.
Intricately related. Like when you enjoy something, when you smell something that reminds you of something positive, so it's a wonderful thing, right? And so we call hedonic. It's things that give you joy. When you lose that people can be very depressed. And we know the INXS drummer who had brain trauma, he damaged his olfactory systems and he committed suicide. So it's a serious thing when people lose their sense of smell. It really, the sense of enjoyment, to recognize things, people lose that ability. And that's why, it's a forgotten area that many people don't look at or look at in depth. And it's something we're really trying to study in detail using high-field MRI.
Right. And so it was the loss of smell and association that kind of led you to identify the nervus terminalis as like one of the potential paths.
The first one was could we see it? Is it on MRI? And there was actually Twitter feed where I've heard about these fibers. Has anyone seen them? But there was nothing in the imaging literature. There was some pathology, beautiful literature that showed pictures of them on path specimens or in the intro-OR, but nobody had published an imaging picture until we published our paper. And now I hope more people publish and look and find them. And you can see them not just on 7 Tesla, you can see them on 3 Tesla. And if you look, you can see them on 1.5 Tesla. If you look carefully along the olfactory bulbs and tracts, which are really low down, like you have to look down into the area, and they're tiny structures, so you have to look very carefully on a heavily T2 weighted MR.
Yeah, so just for my own edification, I'm I think I know, but the 7 Tesla MRI, it's just like way more powerful imaging, right?
Yeah. So exactly, field strength. So we name it after Nikolai Tesla.
Yeah, of course.
You developed alternating current. He was a brilliant, kind of a polymath. He was officially given his name by the Scientific Naming Society. And that's just a measure of magnetic field strength, how strong that external magnet is that we put you in. And the stronger the magnet, the improved signal to ratio, the better resolution we get on higher. We can see structures that might be very small with more detail that we might not appreciate on lower field strength. Exactly right.
And so when you're looking at the nervus terminalis on these 7T MRIs, are you seeing their presentation as different?
Yes, that's a great question.
Yeah.
So the first question was, could we see them, right? Could we actually see these fibers? And yes, we could. We did a paper presentation at Mount Sinai on seeing it to the end, the nervus terminalis. And you could see them on 3, you could see them on 7. They were there. We just didn't pay attention to them. They'd always been there. We hadn't caught them. There's these little tiny little nerve fibers along the olfactory bulging tract. You can see them. They're there. I can see them now whenever I do my imaging. I point them out, and they're not vessels, which have little flow voids. There's these little tiny nerve linear fibers that can be seen, beautifully seen. When you do high resolution imaging, and we share our protocols with whoever would like, can't share the patient information because of HIPAA, but we share the protocols so other people can image them. And I'm sure more people will say, oh, wow, in retrospect, here they are. We just didn't comment on them, or we didn't notice them, or we didn't pay attention to them. And so there's been some beautiful additional research in animal studies, and I hope there's more work. We also have one of our colleagues, Dr. Alice Heford, has gotten grant funding to look at the brain pathology specimens, so we're imaging that as well. But remember, unfortunately, these can be broken if they're not taken out carefully. So I have pictures of past specimens where you see them, kind of these little tiny fibers, but in a patient who's alive, I can look at them and see them if I do dedicated imaging and look in that area. So to me, that's a really fascinating area, because now we want to try to trace these little unmyelinated fibers. Now, unlike the olfactory bulbs and tracts, they're unmyelinated. So if a virus does infect it, it can go more rapidly into the brain, which is what we saw with COVID, versus, the olfactory bulbs and tracts are myelinated tissue. So it's a little slower transmission of that. So we think they're probably the putative entry site for SARS-CoV-2. Of course, we like to look at that in human specimens and look for these little SARS-CoV-2 receptors on these tiny little nerves and measure that. So we're doing ongoing, much more work needs to be done, but it would be key, because if we know that that's where it's entering, and we know where the areas it's going into and affecting, and we also know it's probably coming in through the bloodstream, and how is it getting through the other mechanisms, blood-brain barrier, those are all key questions. And we know we saw these in large perivascular spaces. And to me, those are important, because that relates to what's something called G lymphatic clearance, or lymphatics, which is basically your brain, when you sleep at night, is clearing out waste material. So sleep is critical, right? Sleep is absolutely critical. When you sleep at night, your brain is washing away all this stuff and clearing it out. If it's obstructed, like in Alzheimer's with Alzheimer's proteins, and it can't clear it out, we see changes. If it's got inflammation, which probably affects as well, we may not be clearing that out. So there's little important perivascular spaces, which we saw in large and long COVID, maybe a secondary effect of infection or inflammation blocking those spaces. And there's much work that needs to be done in that area to better understand those mechanisms.
Yeah. So, okay. So here I am trying to catch up, right? But so are we talking about the virus? Like you said that the brain doesn't have a lot of ACE2 receptors. So are we talking about the virus physically getting into the brain, or is it more about like inflammation or the reaction?
Exactly, both. First off, we know we can see changes, right? We know in patients with olfactory volume loss, I could see volume loss along that olfactory bulb and tract. And I could see high T2 signal. So it was inflamed. It was having a problem. But why? It doesn't have ACE2 receptors. So it's probably something that's involved with giving blood supply or innervation to those tissues. That's really critical. And that we know that the nervus terminalis have ACE2 receptors. So looking at that now in humans, if they have ACE2 receptors, is key, because if it is, that might be how that virus is getting in there. That's important, right? Your nose is filtering things out all the time. It's a constant, your immune system in this area is vitally active. It's working overtime to keep you safe and cleaning and clearing things out. But if something can get into the brain, then how is it getting in there and then affecting it, right? It has to have a receptor, right? And it's got to have some tissue that allows it to get in there. It also, we know, is going through the bloodstream at the same time. So how is it getting from that? If you've got this blood-brain barrier, it's designed to protect you, right? And then at night when you sleep, it's designed to clear things out. So we're still working on how exactly it's coming into the brain, which I think requires a little more work on the ACE2 receptors and looking at maybe, past specimens. patients and then tracking those out with biobank specimens, and then which regions of the brain were affected. And we know from the biobank, a lot of those areas are involved with smell and that hedonic adaptation. Those areas were very much involved in patients who passed away.
Yeah. So, this nose to brain pathway it's real, it's happening. What are the practical implications of this?
Oh, huge.
Yeah. What does it change about how we think about like prevention, treatment?
Oh, absolutely. If you can, create some sort of nasal barrier that prevents that going into there, can you, mask? That's why people were masking. It was effective, right? We know that touching your face, like we don't realize it, but we touch our face all the time without even realizing we're doing it. It's a leading cause of spreading infection. So they did a very interesting study where they just told people to keep their hands below like that, like a beeper, and they couldn't raise their hands versus antibiotics. And the hands below was very effective, like preventing infection. So, not touching your face, and when you say it, you want to touch your face, right? So
of course,
and
I'm fighting the urge right now.
I know. Hands, coins, things we touch are very effective. And we also know that when we look at the SARS-CoV-2 virus itself, it was coated with sugar. It's a very sticky viral particle. It's coated with glucose, so it sticks to things. That's why we had to wipe things down with bleach. And it can mutate, right? These viruses mutate over time. That's just what they do. And they're like anything else. They're trying to survive and mutate and get in our system. So patients who were diabetic and patients who were obese had a much worse prognosis with COVID. That is hands down. And we then also published on seizures because we know the temporal lobes were being affected. And we saw that whether inpatient or outpatient, there was a higher risk of seizures that we published on as well. So there's still a lot of work. I personally think that there may be some interplay between how it's coming into the temporal lobe region and maybe interacting with the ARC gene and ARC protein, which is part of your temporal lobe, your hippocampi, that ferries information for you, how you, form your memories that may be involved. And that's still ongoing research that needs to be done in that area. A lot of questions that we still need to answer. We're still working this out. And, we're literally now doing some of this kind of tractography, tracing the olfactory bulbs tracks to the hippocampal regions, to the temporal lobes, to your amygdala, and to these key areas that control your emotions and behavior, and seeing what the effects are in patients who may be depressed with anosmia versus patients who had COVID but didn't get depressed or anosmia. And we see changes. And to me, that's really important because, for somebody who is suffering from it, you want to know why. Is there something that's going on, first off? And then if you identify it, can we treat it or prevent it, or what can we do to help them? And to me, that's important because for patients who are told you've got something wrong and then they don't find anything, you're just like, well, it's all in your head. That's not helping them, right? You need to know what it is. And if we can see that change and then measure it and look at progress and then treat it, that's huge. It gives patients a sense of how we can then go forward and improve things. And I think we're still trying to understand why we have smell loss in Parkinson's, why we have smell loss in Alzheimer's. One of the first things that happens and yet kind of ignored on these patients. And it obviously affects patients, right? And to me, that's important. Like I think if we understand that, then we can work on, okay, how then we treat it, prevent it, improve it, and help patients out.
Yeah. I want to change gears a little bit and talk about cancers.
Yes.
You have highlighted HPV and Epstein-Barr as viruses tied to head and neck cancers.
Absolutely.
I've been hearing about HPV causing cancers my whole life, but how does the viral infection actually lead to these cancers?
Great question. And I love talking about this. So I used to be at Ohio State University. Maura Gillison was there. They noticed that association, right? When patients had HPV. So HPV is a very clever little virus, right? When it goes into the deep basal layers of the tissue. I always find this fascinating to me. When it goes in, then it goes into the cell in the deep basal layers, and it tells it to produce these two key proteins that then block your body's own proteins that help clear things up, right? So if you have like certain proteins that are clearing, like the retinoblastoma protein, or things that are designed to clean out the garbage DNA, it produces proteins that block that.
Is this like the P16 marker?
Yeah. So we call it P16, but it's not because it's HPV 16 is the number one cause, but the 16 is a different reason, right? The number, it's not the same thing. People get that confused.
Right.
It's because when you block those normal proteins that block the ability of the cell to reproduction, it's like I don't know, football or basketball analogy, blocking. It's preventing that person from making the shot, like doing its job, the other proteins to block that. And because of that, those cell replication things get turned on, and it tells the cell, keep going, keep producing more cells, and it's hosting that mechanism. So it starts replicating and producing more viral particles and keeps ramping it up. And it's because it's effectively blocking your own host body to block these proteins. And that's very clever. The virus is producing two key proteins. It blocks the host mechanisms, preventing other proteins from doing their jobs. So the body gets switched on, the cell cycle to replicate, and in doing so produces more viral particles, spreads it to the next, spreads it to the next. Now, why is it only going on? It likes the deep reticulated tissues of the tonsil. We know that. So, and we know it's along the skin. So it's epithelial, it likes those kind of skin tissues. So oral genital, but deep tissues, especially the reticulated tissues of the tonsil. So, but why is one tonsil developing a cancer, not the other? What are the other interplays of the immune system? And maybe we need to think about cancer a little bit differently. Like maybe that some of us are exposed, but our immune system is functioning effectively, gets rid of it. You're immune, you're fine. And we do know, and I cannot emphasize this enough. We do know that when people are vaccinated now for the, Gardasil, cervix, for the young patients, for like the genital urinary cancers using and it's basically a denatured protein and part of the shell. It doesn't have anything to do with it's incredibly effective. It's reducing these cancers. So you have a vaccine that can prevent this. We know that over time, we're looking to see if there's going to be actually reducing oropharyngeal cancers. We don't know that data. It's still pretty new coming out, but it's likely protective. So you have a preventable way of preventing an oral genital cancer with these vaccines, which is like, to me, absolutely essential. And I get horrified when I see what's happening in the country right now, because I know that if you prevent these vaccines, there'll be a secondary effect where these are going to increase in resurgence. We just know it's happening, and we see it happening around the world. And I will tell you, it used to be reportable to see it in a young pediatric patient who had these oral head and neck cancers. If you look in the literature, before the 70s, 60s, it had to be a kid who had a child or somebody who had some bizarre genetic abnormality, like a telomerase deficiency or Fanconi's or something that would really affect the immune system for them to get these cancers. Now we're seeing them in kids who don't have that. So we know the exposure is likely from the HPV. The HPV is getting into those tissues somehow and then replicating, and they're not immunocompromised. These children have other things, but we're seeing them. There's often a delay because nobody can imagine a young kid with like a oral cavity cancer, but we are seeing it reported worldwide, and that's exposure. Now, you have a preventable way of preventing these cancers with the vaccine, and same thing with the other viruses that we see going around in the world. People are too young right now to think about the polio scares and things that happened. People were on iron lungs. It was horrifying. You should be vaccinating for this. And I'm a firm believer that vaccines save lives. I cannot emphasize this enough. As a physician who's now seeing the numbers increasing in my hospitals, people with encephalitis, other things, vaccinate against these things. It saves lives. There's just no question about it. It prevents cancer. It's the long-term effects of these. So if you reverse that, we will see those effects, and we will see them 5-10 years from now, these long-term effects from these viruses. And we know that these viruses are involved in both head and neck cancers. I mean, Epstein-Barr is, for middle age, and the leading cause of nasopharyngeal carcinoma. I mean, that should sink in. These are things that we can now, treat for HPV and prevent using vaccination, which could have long-term effects preventing these other cancers in the future. EBV, they're working on hopefully coming up with some sort of vaccine. And I want you to think about the fact that your immune system is really designed to protect you, but things that destroy it. For example, astronauts, we know that there are some of the healthiest people on the planet, right? Then they leave the planet, right? They get exposed to the cosmic radiation of the sun when they're out in space. That cosmic radiation is very damaging to the immune system. They often get a reactivation of the Epstein-Barr virus, right? Which people don't talk about, because you're destroying that immune system. We normally have the magnetic Earth's field protecting us, kind of shielding us. You leave that protective effect of that Earth, and then exposure, will affect the immune system. So I think we are really now at an edge of relearning how to understand the immune system, especially how the immune system could be used for treating cancer treatments and improving the outcomes in patients with cancer. And I think the future in this is tremendously bright, but there's still a lot we need to understand, and we're using AI. Part of the work in our lab is we're using, I can see things visually, right? But a computer analysis of the DICOM images can take it to another nth degree level that I might not appreciate with the naked eye, and then tell me there's different things in that tissue that make it a more aggressive tumor versus less aggressive tumor, and I can use that to help predict outcomes. For example, I think about the tumor adenoid cystic all the time. This is a tumor that loves to go perineural. It's designed to grow along your nerves, which is also, if you think about it, a little science fiction. Like, things aren't designed to grow along your nerves, but this tumor loves to grow perineural, track along nerves. It also, we know in pathology, is telling me how it's going to behave. I know if a patient is a cribriform, they're going to have a much better prognosis. They're probably going to have maybe lung mets or maybe some other metastases, but they're going to live a long time. Versus a solid form, those tumors behave very aggressively. Those patients have a much worse outcome. I know in pathology, I know that. So we're now taking that data and we're using AI to predict when I see an adenoid cystic, can it tell me, is that a solid versus tubular cribriform? And those predictions are really key, right? Because it's a big difference how you treat those patients, even though it's the same tumor, if I can help predict the type of pathology they have. That is huge. That is changing outcomes for patients and strategizing in a way that they can get the best treatments possible for them at the earliest stage. Absolutely critical.
Yeah. So, I mean, I'm so curious about the perineural cancer spreading, right? Like,
Oh, that is huge. So, oh my God, I'm going to tell you some stuff, and it's just true. In our literature, it's considered acceptable to miss that finding after 50% of the time. That is horrible, right? That's like flipping a coin. That gives
right.
me spilkus or like just anxiety. I don't like that, right? I mean, that's like if me and your brother, and we're saying, oh, it's okay, we're going to miss it. I'm like, no, it's not okay. We know skin cancers have much more high genetic alterations than those that are the deep tissue. So if especially cancer of the skin with squam, it's going to have perineural involvement. But the key question is, why is the tumor growing along the nerves? And is there a mechanism of the tumor that's
Right.
encouraging the nerves to grow to it so that it can say, hey, I can hitch a ride and then track back into the brain and spread. So if you figure out that mechanism, those receptors, what's that tumor's behaving, that's encouraging that perineural spread, that's huge because you can block that mechanism. Patients live a lot longer. Patients don't die from that primary tumor. I want you to think about this. You're not going to die because you got the little tumor there. You die because the tumor spreads and grows. You die because the tumor gets to places it shouldn't be getting and then causes a lot of damage. If you can block that spread, you can prevent that and just keep removing that patient can live a long time. You change the outcomes for those patients. And that's really key. And the fact that certain tumors, especially squamous cell carcinoma, in this region of the skin, loves to get on those nerves, that's the fifth or seventh, and track back into the brain and cause problems. We can see that on imaging way before they're clinically symptomatic. And to me, that's absolutely critical. We make the diagnosis as soon as possible for the patients, for the outcomes. And I have a TED Talk on this called Hitchhikers and for perineural spread, because tumors basically hitchhiking and growing
Right.
along. And as part of that talk, people say, well, patients have this and blah, blah, and the outcome, are you making a difference? And there's a great parable of the story of the little girl throwing the starfish in the water. They've all washed up on shore. And the guy says, there's thousands of starfish. And she throws and she says, made a difference to that one. So if I can make a difference in any patient and improve their outcome, that's your goal. That's what we're taught in medicine to do. How can we improve those outcomes? So it doesn't matter how many people are affected or what. If we figure that mechanism out, improve it even for one, then apply it for another, then we can improve outcomes for a lot of patients over time. And I think that is one of the key goals in medicine is understand the mechanism, understand why it's doing that. And then if you can prevent it or figure out treatments for it, the outcomes change. And that's truly a remarkable thing. If you've changed the outcome for someone, that's life-changing for that person. And that is our goal.
We have a few minutes left, but before I want to start wrapping up, I have to ask, right? So you're talking about the perineural spread, both with like a squamous cell carcinoma, like a skin cancer, also with these, these viral initiated cancers. I'm curious, do you think that the like viral biology affects like this hitchhiking behavior?
That's a great question. Absolutely. So we know that when patients have a HPV-related cancer, it's often a teeny tiny primary, but they often present with like a big cystic lymph node in the neck. Why is that? Why is it it's going more into lymphatics? It's cleared out maybe by the viral system, leading to this larger reaction in the node and just a tiny primary versus, people who smoke and drink, it's damaging that cellular DNA tissue on the superficial layers.
Right.
Often kind of involves those layers and for smoking, drinking. But what happens if you've got somebody who's got both the virus and smoking and drinking? What's happening in that interplay? And we know that there's both EBV, which can cause a nasopharyngeal carcinoma, right? That's in certain, and if you're doing things that may be exposing to certain carcinogens and diet or whatever, maybe it's affecting that as well. So there's a lot. I think to me, there's no question that that virus is triggering and altering the DNA, right? And how it does that is key. And then leading to the replication of certain, oncogenes forming behavior that said, hey, let's replicate and cause a tumor. But then how do we prevent that? And I think we're still figuring and learning out many of those mechanisms. And the more we understand it, the better we can basically treat and have improved outcomes for patients. We know if we find someone with demyelinating disease, which are getting on treatments earlier, they're going to have a better outcome. So, risk factors, why you have those risks, what can we do? How can we improve it? To me, those are all essential. And using all the information and tools in the toolkit, and AI has a lot of tools in the toolkit that I find incredibly helpful and useful in that regard.
Yeah. So let's zoom out a little bit. I know you've talked a lot, and there's all these parallels and paths and intersections throughout everything that you're working on, both literal paths and metaphorical paths. I'm curious, what is this unifying thread between your COVID work and, the viral related cancer work? What do those connections look like?
Big risk factors. So what I've really found that big risk factors especially include, and this is something else we need to talk about because I've done AI work on this as well. Obesity is a big risk factor. Obesity is a disease, right? And we know that in patients who have obesity, they did worse prognosis in SARS-CoV-2. They have worse prognosis when we have high risk for developing Epstein-Barr with other diseases. We also saw venous thrombosis and other changes. So it has a lot of in play with that. So we know that's a key risk factor. Why? In demyelination, I personally believe it may be exposure to certain myelin fat type proteins that then the body causes the immune system. To me, it's a unifying thread that both diabetes and obesity, which are diseases, are risk factors. Now, we also get in the GLP-1 drugs. We now actually have a medical treatment for reducing obesity, which is game-changing for a lot of people. It's a game changer, and we'll see obesity be reduced over time. So that might have implications for what happens in cancer in patients over time, and we see that. I think we're always going to have viruses around us mutating. There's probably more that we don't know or understand, but I do think that we know that they are going to interplay in the body with inflammation, and we know that obesity leads to increased inflammation and elevated sugar levels and diabetes. All of those play a key role, and we're still understanding those exact mechanisms. But we do know if you can reduce your, hemoglobin A1C, you can reduce your obesity risk factors, patients will do better. They do better in the long term. Why? Probably related to immune system and inflammation, and we're understanding those underpinnings of the immune system. I am a firm believer that, imaging, if we can identify early, and if we make the call, if you're aware to what to look for, you're going to see what you know, right? If you find that perineural spread early, you're going to change the treatment algorithms and hopefully the outcomes of the patients. So being aware of that anatomy and how that anatomy is interacting in the environment, absolutely essential, critical, and for what we do in our job.
So, what would you say to potential patients or clinicians who may not be getting, this level of imaging done?
Vaccines, right? Vaccines are key. Vaccines are going to save your life. We looked at patients who were vaccinated versus unvaccinated with what are called venous thrombosis in the brain. We looked at the difference in that, and patients who were unvaccinated, it was a far worse prognosis. There was just no question. It was no question. So vaccines are essential in the long term of helping save people's outcomes. There was just no question. We know that it's a protective effect if you get immunized against these HPV things. It's protective. It's huge. Obviously you can do certain things. People got the message. People are smart, right? The people out there want to know. Nobody's out there saying, I want to destroy myself. People want to do the right things, essentially. People got the message in smoking and drinking. So a lot of people stopped smoking and drinking, but the awareness that it can be transmitted to other things. Like if you're smoking a joint, you're sharing your saliva with somebody else and it's got HPV, you're getting that HPV virus. When you share certain things, you're going to expose yourself. So you need to be aware of that, right? Prevent that, be smart in your behaviors, but also, wash your hands, which is just a basic thing. Don't touch your face, hard to do, right? But also just, exactly, keep the hands down. And I like to use mine for talking, so it's really hard. But also seeing your doctor regularly for a checkup, because you can be screened for things early on. And, you catch it early makes a big difference than if we catch it late. It's a big difference in outcomes. So earlier detection and prevention are huge. Get your colonoscopy, get your mammogram, do these things that are just kind of expected routine, because if you catch it early, it changes the outcome before you can let it grow, before it becomes allowed to spread and become a problem. And to me, that's a huge message. It's just common sense, and, get vaccinated. I don't care what else anybody else is saying out there. You're smart enough to know. Look at the literature. read the literature, read the room, follow the people that know what's the best for you. And your physicians are in agreement on this. And there's no question about that.
All right. I feel like that's a beautiful place to stop.
Yeah.
Is there anything else you wanted to touch on?
Oh, Chris, it's honestly, I'm honored and a pleasure to be here to get a chance to talk about doing stuff I love. My thesis is in. I have my defense coming up. So, we have multiple publications on it. So, which has been exciting, but still a lot to learn. So I want to do a shout out. I'm really lucky to have worked with the people that I've gotten to work with as my advisors. I need to do a shout out to them. I am honored and lucky to work with them. So to me, I owe them a debt of gratitude that, I feel incredibly grateful to be working with the people that I've been working with around the world, around the country. So very, very lucky.
Beautiful. Well, thank you so much for joining us. Today's guest was Dr. Claudia Kirsch, professor of neuroradiology at Yale School of Medicine and almost no longer a PhD candidate. Claudia, thank you so much for joining us today on Rethink Imaging. It's been just truly wonderful having you today.
Chris, thanks so much. It's absolutely been a pleasure. I hope you have a great rest of the day.
Thanks. You too.
Frame by Frame Rethink Imaging is brought to you by Immunologics. Here, you'll find engaging interviews with thought leaders, experts, and patients, sharing stories that showcase the transformative power of medical imaging. To discover how Immunologics is rethinking imaging and healthcare, visit Immunologics.com. Be sure to subscribe to Frame by Frame Rethink Imaging on Apple Podcasts, Spotify, or wherever you listen. And from all of us here at Immunologics, thanks for tuning in.